evening, everyone. My name is Julia Topman. I am a Practice Support Officer for Southwestern Sydney PHN. Welcome to this information session regarding more cleaner air and the right mask for the right occasion. I would like to begin by acknowledging the traditional custodians of the land on which we meet today. I would like to pay my respect to the elders past, present and future, and extend that respect to those in the meeting who identify as Aboriginal and Torres Strait Islander people. Just a few housekeeping items to be mindful of. This meeting will be recorded. Everyone will be muted throughout the session. Therefore, if anyone has any questions, please type it into the chat. Please inform us through the chat if you are sharing the same login with a colleague so that we can issue certificates accordingly. Please complete the online evaluation at the end of the session. The link will be posted in the chat. Please be advised that participants are required to stay for the duration of the meeting in order to receive a certificate of attendance. Certificates will be issued within 1 week. I would like to introduce you to our speaker for this evening, Margaret Jennings. Margaret is a microbiologist and infection prevention and control consultant and educator. I will now hand it over to Margaret. Thank you, Margaret.
Thank you, Julia, and greetings from Wurundjeri country. So I'm in the northeast tip of Melbourne, and just thinking about where we are in terms of, a tale of two cities. So the rate of increase for New South Wales probably peaked. This is the rate of increase, not the number of cases. The rate of increase probably peaked around about mid-August. And so your curve kind of going like that. Ours is like that. So we're doubling every 7 days at present, which isn't great. Now I'm just going to see if I can get myself onto full. Hang on, I'm just going to play. No, I've put it onto Julia. Okay, I'll just make it full screen. Okay, so I'm in the top quarter. The reason I've had that fiddle is that I'll be putting stuff on and I actually need my glasses, and I was hoping to be without my glasses so that I could actually see what I was doing without them. So one of the things that I think we need to really have this discussion about, because it's part of the key to reducing risk, and that is about understanding airflow, air exchanges, and what things are not fresh air. So just to introduce you to some terminology. So you'll maybe not hear, but I'll give you the term. It's called HVAC, heating, ventilation, air conditioning. And we have this in our homes, we have this in hospitals, and it's really not about infection prevention control, it's about comfort. So, if you're a practice who's in a shopping centre, there'll be so many changes per hour in your HVAC system, and it's just for comfort. What we do know is that you need incoming fresh air and obviously stale air going. If I look at a hospital, what the hospitals are doing is increasing the air changes from, say, 4 to 6 right up to maybe 10 or so. And also they're putting high-risk patients or positive patients in mainly negative pressure rooms. Now, we don't have that luxury in general practice, but I'll tell you what most of us have, or a lot of us have, a front and a back door. And if you really want to understand what's going on with the virus and how it just gathers, it's really about saying, have I got air being pulled through my practice? So for those of you who've got a front and back door, and preferably a security screen on each, you don't want, the flies blowing in, I'm going to advise opening the doors and windows. With the windows, if you're in a consulting room, and hopefully nobody is using a waiting room in Victoria or New South Wales right now, you would have the door open and the door to your consulting room, which you're generally not even using to see patients in. But if you've got a window for your consulting room, you would leave that and the door open. So that would become a part of the cross ventilation. So what we know is that replacement by fresh air of stale air is one arm that we've got in our list of things. So we don't have negative pressure rooms. We don't have, 10 to 12 mechanical air changes an hour. We don't necessarily have machines in general practice, but you can buy one. You can buy a portable, for one room, an air cleaner, air purifier. You can buy one of those for $800, and the air passes through a HEPA filter, and it will clean the air in about 6 minutes, just roughly. And I can send this paper on to the PHN if you want to read it, but they actually did a study and 2 parts really, but at the Royal Melbourne last year, why were people in the next room getting COVID who came in not with COVID, but why did they end up? They had brought in a lot of people from aged care who were deconditioned and weren't being fed, etc., because of the outbreaks there. And so they brought them all in, but they couldn't work out why it got from one person to another. They looked at the PPE that the staff were wearing, the full bit. And it wasn't until they did the smoke studies where they saw that the smoke was going under the door, out into the corridor, and under the next room, into the next room. So this got people very busy, excited. And so since then, there's been a lot of work done to show that, if you can't get negative air pressure, then or cross ventilation, then possibly a portable cleaner air room purifier, portable, might be the go. So I'm not suggesting that people go out and buy one, but have a look at how you can achieve good cross ventilation. So the pandemic planning asks us to look at 3 things to risk reduce. And it says, look at admin, and what they're really talking about there is contactless, no paper, no exchange, no money, etc. They're looking at just nobody in the waiting room, the way we run our practice. So it's about delivering medicine using an alternative model. And it doesn't always mean telehealth. I'm actually very keen for the practices to see patients, not necessarily inside, but outside, because that we are losing patients because they're not coming to be seen to have their, maybe their oxygen level is right down and they need to be going to hospital, etc. So I don't think we have to do telehealth all the time. We can do it a lot, of course. We don't have to have the patients inside, but we can definitely see them in a car park, outside on a chair, etc., etc. So I'm not actually discussing the immunisation setup at present. So engineering is the second arm that the pandemic planning asks us to look at to risk reduce, and that is about air and movement and stuff like that. What I can tell you is that and of course the third arm is PPE, but I want you to picture your consulting room. So think about your consulting room at present. The window doesn't open, gets a bit stuffy after 2 or 3 patients have been in. What's actually happening in there? So what's happening is as we talk, and I'm even meaning when we have masks on, but obviously to a lesser degree, but when we talk, we emit particles of evaporated bits of spit and snot, not even always evaporated, sometimes feel a bit wet when you think about a baby sneezing on you. So what happens is these particles of different sizes come out of our respiratory tract. So some of them are large. As I said, sometimes you can feel the wet sneeze from a child on your face, large bits, but they also fall to the floor. So the person coughs, talks, just talking, even breathing, large particles drop to the floor really within about 1 metre or 2. And that's why, you might have heard this distance, about 1.5 metre. But more importantly, it's not just that everything falls that quickly, and it's not that everything is large in size that comes out of your respiratory tract. So there's medium size, there's a whole continuum of sizes of particles that come out of your respiratory tract. And of course, there's the really tiny, tiny bits of spit and snot, and these tend to dry off and can remain airborne for some time. So unlike the large droplets that fall to the floor straight away and actually don't tend to pose a problem unless you're, close. I'm thinking of the common cold. These tiny ones dry off and hang. They just hang. So I think you can then see what a room with somebody or an ICU with people with COVID is now beginning to look like. So I'm now getting this accumulation. People don't always have stuff all over their face, masks or special equipment over their faces necessarily. In ICU, there's lots and lots of equipment. It's changed. And so I'm going to get, quite a flood of airborne particles. Okay. Then you breathe that in. And maybe you're only wearing a surgical mask. So what they're doing, as you know, is they are using negative pressure. They are maybe even using air purifiers and increased air changes. And of course, they've switched over to the P2 respirator mask. And that's about the best you can do in ICU because you can't reduce time. You really can't reduce the contact you have with the person. It's it's intensive. But these are actually all things that we can control in general practice. So we can see the patient outside where you have unlimited air changes. I'm not suggesting it's risk-free. And of course we wear PPE. But perhaps we don't actually need to wear the P2 mask. If I was sticking my head in somebody's car and they had symptoms, I'd definitely have a P2 mask on. And in Victoria at present, for what we call Tier 1 level PPE, it's surgical masks and a face shield. That's what we're wearing automatically in the clinics, all staff. So whether you go outside or the patient comes inside for an immunisation or something and they're low risk, obviously checked, then that's what we're wearing. The need for a gown, the evidence is not strong that infection is being transmitted of clothing, etc. But it's certainly prudent to be wearing a gown when you are with somebody who is high risk of suspicion there or known positive. And that really shouldn't be the case in general practice. We shouldn't be getting up close to a suspect person. But certainly if you're asked to go out to the car park and the person has symptoms, then at least wear the P2 mask and the face shield. So that thing about the air particles hanging there, I think that should be enough to give us a really clear picture of why we wouldn't be seeing patient after patient in our consulting room. Because eventually somebody will come in who is positive. And we base a lot of this on the fact that we treat everybody basically as possibly positive. Even we know that some are much lower risk than others. Some people insist on wearing full PPE for every single patient they see and feel quite protected, and they're happy to see them inside, but I see them wandering around the clinic still touching everything. And in fact, what happens, the more PPE you wear for a longer time, of course you change your gloves between every patient and if you're in full PPE, high level, but what happens is you tire, you fatigue. It's much better to have the minimum necessary PPE and use it really prudently. If I saw somebody who was symptomatic, I'd actually change my mask because I would not necessarily need a P2 mask for the next patient, but that's what I would do. So thinking about air, we can have our front and back door open. I've also got to think about not having people in the waiting room. They're quite near the receptionist. And although the receptionist has got a mask and face shield, I prefer a face shield to goggles. I know it says eye protection, but think of people who wear glasses, much easier to have the face shield. There are some negatives about the face shield in that it doesn't fit and doesn't always give you fabulous protection here. But in terms of wearability, a lot of people just find it much easier. I'm going to show you how to clean one as well in a second. So I'm thinking of my admin and I'm thinking of the fact they've got sneeze shields, but sneeze shields really only protect against the droplets. And I just don't think I'd want to have people waiting in my waiting room at all, even if my windows are open. So look at all the ways you can reduce risk. And they're all additive. Each one I do reduce risk a bit more. So it's not all about PPE. It's important. It's not all about air, but that's important. And it's not all about, the administration side. To give you some perspective, there was a big focus on cleaning earlier on, 18 months ago. And that's, I'm not saying that we've gone all slack and we don't clean, but we've learned a few things about what we call contact transmission. And it just doesn't seem to be strong in the non-healthcare setting. Haven't got good evidence for that. A little bit of evidence, but I shouldn't sort of say it's really strong. But what we do know, it's really occurring in healthcare, where people will touch a touchpad with contaminated gloves, forget to wipe it. Next person comes along and I don't know why, but for some reason it gets back to their eyes or mouth. Why have we introduced the face shields? And what is the advantage of the face shield over the goggles? Well, it simply stops you touching your mouth, as well as providing a barrier and being easy for people who wear glasses. It actually stops you touching your mask. And that's really quite important, because as soon as you touch your mask, you're committed to doing your hands. I mean, you should do your hands anyway if you touch your face shield. But in some instances, you'd actually be required then to change the mask. One of the questions that people ask is, how long does my mask last? So I'm talking about the surgical mask that most of you will be wearing most of the time. And this is 3-layer. I've actually cut one up. You've probably seen me do this before, but there are the 3 layers. You always wear colour out. That catches a fair few of the droplets. Then there's a middle layer, which, feels for all the world like skin. And then there's the inner layer that you wear against there. So this is doing a lot of the heavy lifting too, this inner layer, because what I'm actually trying to do is breathe through that. And to do this, and again, you're probably sick of it, always do our hands first before we put the mask on. So the bread tie, I call it the bread tie, it's for the nose bridge, about 1/3 of the way down the nose. So I make it like that and I have it flat. Don't do that. Okay, if I do that, I end up with a pocket, and the air, of course, will find least resistance is here, and I'll start breathing in through the sides. If your face is very small, consider it a child's mask, okay? And I find this is putting my glasses on. If I've made a nice little and there, then I don't get fogging up. But if you wear your glasses back, or this is loose, such as like that, you'll end up in all sorts of bother. Avoid touching it. If you touch it, do your hands. To remove it, there's only one way, and that's 2 hands away and down. And there's only one place for it, and that's the bin. Not your pocket, not the coffee table. And again, we're not using tea rooms either, are we? So why don't we use tea rooms? Well, we kind of fall into that fatal idea that somehow it's the patients who are infectious and not us. And I have to tell you, it's not the case. So we do know that a number of healthcare workers become infected. 2 receptionists at the same reception, but they're telling me they're 1.5 metres apart and they've both become infected. Well, 1.5 metres is not enough for this virus. Okay, this is Delta strain we're talking about. Outside, it might be enough, but inside, I'm telling you, if that virus is in there, it's going to, just keep on accumulating and not being carried away. So no, we don't put a fan on, and no, we don't turn the air conditioning up to blast, but true air exchange is actually what we're after. That's not to say that some systems don't, clear the air and exchange it, but you'd need to find that out from the building owner, whether that's actually happening. But as I said, the cheapest and quickest thing. So I'm thinking about, even though I don't have patients in my practice, how can I keep all my staff safe? So with the tea room, it's just go there for your tea or coffee, take it outside. Lots of practices have rigged up something out the back with a couple of chairs just so the staff can have somewhere to sit and just get away from the world for a minute. Lots of staff take a thermos to work and leave it in their car and actually go out there to have their break. They can take their masks off, sit in their car for 10, 15 minutes and just forget about the world, which leads me to mental health breaks and how long the mask lasts. And I'm going to get onto the P2 in a minute. But with the surgical masks, really, when they get wet, they just become ineffective. And although, you know, they've written heroically that these can be worn up to 4 hours, I'm a little bit concerned when people wear them for that long. Because two things are happening, you know, when I think about this. They're going to be wet, really. I mean, I can't see that they're not wet by 3 hours. In fact, sometimes if you're doing huffing, you know, really huffing and puffing around, you know, the park, you know that either you can't even wear your mask when you're exercising or else you will get wet quite quickly. Somebody's asked if you've got to wear the hijab. So you know that there's a clip that can just go around the back of your scarf and we don't wear it over our ear. So hopefully that's answered that question. But yeah, and also a lot of people with problems with the loops really kind of abrading behind their ears have also gone to the clip. It's a little clip in both ends of the loop tie. So hopefully I've answered that. So don't use your tea room. Have good airflow. Check each other every day before you come to work. And also check what's going on in your household. You know, I really don't think we should be working together when somebody has a 15-year-old with a sore throat in their house. So have a chat to your families and say, you know, we're a little bit serious. We're healthcare workers, whether we're in admin or practice managing or whatever. But, you know, I need to know if anybody in this house, and some of us are in multi-generational houses, I need to know if anybody's got a headache, a sore throat. You know, with Delta, if you're immunised or a child, it's really the runny nose and headache that's right up the top there. And of course, a lot of us are immunised, and you know that you still can get it. You tend to get it not as badly, and you don't tend to be able to be as infectious. But there are some of the things to look out for. Normally, it's the sore throat. Look, fever, honestly, I think a lot of people have given up taking temperatures. We know about 40% of people will get a temperature, but I'm far more interested in the symptoms. And, you know, for your asthmatics, you're looking for a change in symptoms that they may have had, you know, regarding the cough. So getting back to the tea room, no, we're just using it to grab our food, wipe over the surfaces that you touch a couple of times a day. This needs to come off. I would say to the managers, just tap your staff on the shoulder, you know, every 3 hours. I would expect at least 2 changes a day with your surgical mask. I just think you need those breaks. And so use that opportunity. And look, some staff might say, I'm just lucky to get a break. But really, I would really advise, you know, maybe a 10-minute break and then a 20-minute break, you know, where you can have lunch, et cetera, et cetera. But you've got to have those breaks. So that's about taking the mask off and just relieving, you know, some of the pressure, et cetera, there. And with the P2 mask, that's really important. And then going to the loo, to the toilet, wash your hands, of course, and then go to the tea room, grab your cup of tea. So, and then have your, you know, 5 minutes what's left of it. So that to me is about, yeah, looking after each other, because I hear people say, oh, I just wore the same mask all day. Well, here's me thinking, well, that mask isn't working after a few hours. So that would be like organisational. That would be what the pandemic would refer to as admin. You know, that's part of looking after our staff and making sure they're going to be changing PPE and getting those breaks. What else can I add to that? I'm not going to mix up the wearing of masks out in the public, but we wear surgical masks at work. We do not wear cloth masks. If there are people who absolutely can't wear a mask, and there are very few, but I tell you what, they're popping up in my suburb at a great rate. They've even got badges saying medically exempt. And I say to them, well, what are you doing to protect me? You know, stay away. At least put a face shield on. But if you've got, I was going on about the two secretaries, some of them say to me, well, you know, do I need to wear a face shield if I've got the screen in front of me? And my answer is yes, because we are in the middle of a global pandemic. Is there something we're not understanding here? And even if you're double vaxxed, which I just hope everybody is, because this is literally all that is going to work for us at present. This is a highly infectious bug. I'm to talk about the effective reproduction number here. That's about how many people this can infect. If you look at the original Wuhan strain, it was maybe about, 2.2 people that each person could infect. And then the Alpha variant from the UK, that was maybe a bit more, 3 point something. Well, this thing is really 6 to 8, and that's really putting it up there. It's not as high as, say, measles, which can be up 16, 17, or whooping cough, which can be around 32, but they're immunisable diseases that we've been able to jump on. Influenza as a comparison is around about maybe 2 as well. So here we have this beast. I've got a model. There it is. What do we know about it? Well, it's an RNA virus, but we also know it's got an envelope, a little fatty envelope. And you can see the spikes stick out from that little fatty envelope. So when I use my hand rub, I am dissolving or damaging the envelope, and that stops this from attaching to my throat. Hand hygiene, really important. Little lesson on the use of the alcohol, always 2 hands. No going past it like that, you'll never put enough on. So no jewellery. I don't think anybody's worn jewellery. Well, I haven't, probably for about a year and a half. No nail polish, no fake nails, no jewellery. If you can't get your wedding band off, then you're just going to take more time to get the alcohol in and behind it. But certainly no mounted jewellery at all. And that includes everybody working in the practice, because we need this to access all parts of your skin equally, be able to rub it in all over, and just picture it getting to that virus, so that when you do eventually touch your mouth, which you will when you're eating and drinking, etc., then at least you haven't got it on your hands. So to use it correctly, good couple of mils, dip my fingernails in, now rub it all over my hands. You can see it's all glistening wet. Now rub it in really well. So none of this, you've got to rub it in really well. And it's still got to be wet at 15 seconds, maybe just going a little bit sticky by about 20 seconds. You can probably get gloves on if you're doing that sort of work by about 25. So it's just going sticky now. But if I just go like that and it's dry in 5 seconds, I've not damaged the envelope and I haven't done my hand hygiene enough. To look after your skin, make sure you use basically a compatible brand. And the best time to use it, I've put way too much on here, but I'll show you what I do when I do that, is before you start work. So go to work, do your hands, wash your hands. If you put too much, do your forearms, all right? Keep rubbing it in. And what this does before you start work is put back some of the moisture and oil, reduces loss of oil and moisture, so that when you are doing your hands with a hand rub or washing during the day, you're not losing as much oil and moisture. So the general recommendation is 2 to 4 times a day. At home, before you go to bed, pop some on that you've just got yourself. But at work, use the one that's provided, and it really does need to be provided. Hand Hygiene Australia, say that we're not engaged with hand hygiene unless we're doing hand care. Now, let's compare the 2 masks. So you've got your air sorted, you've got some air moving around your practice, good, tick. Haven't got patients in the waiting room, not using the tea room, checking us when we get to work, making sure we are okay, no new symptoms, checking our patients, seeing patients outside, all of those things, as well as making a choice. So what I can say about this is I've got 3 layers and I'm taking in most of my air if I wear this correctly through here. But where there's a risk that I'm going to contract this beast and even worse, pass it on, is that I would look at a mask, a respirator mask, that fits really well and a bit trickier to wear, and you've got to do what we call a fit check every time you put one of these on, every time. Then you're supposed to have, in line with best practice, gold standard, be checked with a special machine, a person using a special machine to perform what we call a fit test. So if your practice has purchased a particular type of P2 respirator, you work out, well, when am I going to wear it? I'm going to wear it when I've got a symptomatic patient, regardless of their test results, regardless of anything, if they have any respiratory symptoms, and I actually might include gastro as well, because you can get a vomiting diarrhea for some patients with COVID. So when am I going to wear it? Am I going to get it fit tested? I'm going to have to call up a company to get somebody to come and, fit test it for me. And we're going to have this particular brand or that particular brand. So there's a number of brands on the market, but what you would avoid when you purchase these is one with ear loops. You can't fit check or fit test a P2 mask with ear loops. They are dodgy. Also, we do not have a valve with a P2, because what that means is the air that comes in is filtered, but guess what? I'm breathing all of my dirty stuff out. So no, we don't do that. So we treat this as both protective for us and protective for others. If I'm in front of my patient outside in the car park and I've got one of these on and they've got one of those on, together we're probably reducing risk by about 70%. There's a bit of give and take either way. If I wear this, the patient still wears this. Yes, it does go up. I'm not going to say it goes up, or it can't go up 50%, but it might go up another 10, 15%. So it's not the only thing we do, is the P2. Having said that, I'm going to show you how to fit check it. But I really just would expect, unless you're otherwise advised, unless you're with suspect COVID patients, even outside, that's when I wear that. But otherwise, unless it's suspect or you're advised or known. Okay, so this is in the high risk situation. So I do my hands before I put the mask on, and you'll feel again, there's a part at the top that feels quite rigid. So I put my mouth in, nose, and I put one on the top and one at the back. Okay. Now, if you have hair like mine, which is really frizzy, you might want to wear a cap, or you've got long hair, and that stops hair getting into the mask, into the side there, because that can affect the seal. So I've actually put it on the top, one below the ears. I then come round to the front, and about a third of the way down, I press in the nose bridge. And I feel all the way around, no hair. I pinch it a bit more and do a bit of a yawn. Now I do some heavy breathing and it collapses. Now, some of you might have the rigid one that doesn't collapse, but you're looking to see that there's no hot air coming out of here or cool air whistling in. So if I did, I just felt something coming out there. So what I do is I do it again, fit it all around, third of the way down, and then pinch a bit more, and then breathe. So that is what we call a fit check. Then I will put on my face shield. Now, this isn't the best one in the world because it's got some sponge on it, and I think you can see that it's probably meant for the bin after one use. However, we're a bit stuck, aren't we? We've just got to improvise a bit. And it's very difficult. You can't really disinfect sponge, but I might be able to at least wipe it over a bit. Again, not perfect. So do take notice of the instructions, but try and get ones that are all plastic and no gap. You want it, not allowing anything to fall in. So when you put it on, and you would have already had your gown on anyway, you're going out and sticking your head in somebody's car, that kind of thing, who's got symptoms. So I'm just going to deal with the head first. So this will give my eyes some protection, but you can see that there's a bit of a gap at the side, so it's not perfect. If you want, you can wear the goggles. But for somebody like me who wears glasses, I would find enormous pressure on my nose. So it's always going to be about how I'm directed. Now, when I'm finished seeing the patient who was a risk, high risk, I wouldn't just leave all this on. If I was seeing 10 patients in a row, one after the other in their cars, and they're all high risk, I would leave this on and I would change my gloves person to person. That is called extended use, not reuse, but extended use. But let's say I'm just talking about a one-off. So I've gone out, I've got all my stuff on, and I'll come back and I would take off my gloves, do my hands, take off my gown, do my hands, then I come to my face. So we only ever touch the back, and we actually clean this. So I grab, it can be paper towel and detergent, or it can be a detergent wipe, and I clean the inside. Let's see. Then the outside, try and turn it over so it looks a bit cleaner. Then I would grab some disinfectant, whether that's, some ViraClean and paper towel, or disinfectant wipe there. And then I would go over the front. If you wanted to be really super accurate, do your hands in between even those two. This is what I've taken off because I'm going to go off and have a break. And I could pop it in, leave it nice and wet, with the disinfectant. It's got to stay wet. But it's in my bag and it's on my hook, and that's mine. That's what I'm using. You see that it's hard to wipe across the top. So, that's why you perhaps wouldn't have that one that I've got. Now, to take this off, grab one, grab two, away and down and into the bin. So these are not reused. There's really no case for that. Right. So any questions there on the PPE? I just will look. Anything coming up for you, Julia? Everybody's gone off to sleep?
No, I haven't got any other questions that have come up.
Good, good. Now, returning to what this does. So we call this a P2/N95, or you might see the K. K means, I think it's Korean, to Korean standard. I think the P2 is maybe British and the N95 might be American, but whatever it is, it all means the same thing. And it means that, 95% of particles, not virus, but 95% of particles to a particular size are filtered out. You cannot actually filter out a virus, but the virus is usually attached to the bits of spit and snot. And if it's attached to the really tiny, tiny bits of spit and snot, then this will give you some protection. But having said that, this also gives you some. This gives you more. But if you're going to wear this, it's going to have to be fit checked and stay like that. How long can I wear these? Can I say that if you do decide to wear these just all day, well, you're going to have to change it again every 2 and 3, at least 3 times a day. But you need to make sure you've got access to a regular supply. And I think rather than just practices decide, I think we'll just go over to P2, it's about, well, how are people wearing them? And I'm actually wearing them effectively. So for me, I'd be a little bit more selective and just say, I will wear these on the occasion, Matt. A, I'm directed. 2, I'm not having patients inside the practice, and I'm not having staff who are from families where there is any symptoms. I'm not having that. So it's going to be a fairly low risk practice. I'm going to have all the windows and doors open, and we're not going to do certain things. And therefore, when I use this, it will be because I'm in a high risk situation, or even suspect or known, and I've got to stick my head in the car or get really close up to somebody. If a patient has got to come in for an examination, my advice is use a separate room to the one that you're doing your telehealth in, and your cups of tea or whatever, if you're taking them back to your consulting room. You can imagine if you decide to see a patient in your own consulting room and then you take your mask off after they go to do your telehealth, all you're doing is inhaling the air that's been sitting there where you cannot open, doors and windows. So I'm very keen for the doctors to look at either a colleague's room that's not being used that day, to look at patients if the patient needs to come inside to be examined. Certainly you can take your little oximeters out and check oxygen saturation on patients there, or you can use the treatment room. So have a think when you go to work each day, what rooms are available should a patient need to be examined. Again, I wouldn't be having patients who are symptomatic inside the practice, but I want patients to come because they may need to be checked. They might say that they're okay. Oh, I had a bit of a sore throat a couple of days ago, but I'm okay. No, I didn't have a test. Okay. And also people deciding that they haven't got it, that's the space that some people get into. So the PHU has recently advised me that surgical masks are grossly inadequate in general practice. Yep, depending on the situation. Depending on the situation, they can be. As I said, it's not just about the PPE. Certainly in a hospital, ED, etc., and ICU, you'd be mad to just wear the surgical mask because you don't know who's coming in. But if you were seeing patients outside, then the requirement for a P2 might be very different. I've suggested if you've got to, get near the patient in the car, that's certainly the case. But I'm very reluctant for you to see patients inside. With the treatment room, if the treatment room has an external door, then that again increases air exchange. But I wouldn't be making that my habit. So yes, I'm with the public health unit in that they're inadequate, but I'm also saying that P2 masks are not the only way to go either. That it's really looking at a number of balls in the air at the one time. What I can tell you is that where the staff are vaccinated, and they're doing this in the Melbourne hospitals now, they're switching over to if the staff are vaccinated and using P2s, then they won't necessarily be having to be furloughed if there's an exposure, or if it's an exposure site. And you can see why you would do that. How much time will be needed to wait to see one patient after the other for face-to-face? Well, I've just expressed face-to-face can be outside. Okay, face-to-face can be outside. Nobody's using the waiting room. Practices have said to me, oh, look, if a patient does have to come inside, the other thing too is that they get rid of their old mask, do their hands, take a fresh mask and put it on completely. But, I think, well, if you've seen 32 patients normally face-to-face per day, I'd be surprised if you're seeing one or two. But we don't, and I mean inside, I'd be surprised. How effective is an air purifier? No, I don't necessarily recommend it for all GPs, and it is related to, its capacity is related to room size. You can't just sort of plonk a little weenie one like that in a room, expect it to do its thing. So I might send those papers on to Julia and Christina, but it is just like maybe one more option in terms of engineering. Much better to have those doors open. Well, no, I shouldn't say much better, but also think about what we can do now that literally doesn't cost us anything. But have we been relying on our PPE without thinking, oh yeah, I do take my P2 mask off when the patient's gone and I sit there and I do my telehealth. Well, what was the point of the P2 mask? Because now you're just breathing in everything that has been sitting in the air. So you can see why I'm, why I'm that keen. Also, in terms of what the PHU say, I can tell you that when you look at the national guideline, it doesn't say that they're useless. Got to be careful what words we use here, but it will actually direct me when to use a P2 N95. And it says, make sure you're fit checked and do get fit testing as well. So, and make sure you've got enough. I mean, that would be the first question I'd ask. Are you prepared if you're wearing a P2, to have 3 changes, well, you know, 2 changes a day, that's 3 masks per person over a week. Well, that's a couple of hundred masks. And was that really absolutely necessary? So it actually gives you some advice. So that's the national guideline there. With I've been sent this by from New South Wales Health there. I've got to say, it's actually an exposure risk assessment matrix. And I don't think it's actually what we need to be using necessarily to guide us with PPE, but I'm very keen to keep you in the green zones. This is the risk matrix. And yes, you will end up in the blue zone a bit, but I'm really keen to keep you out of yellow and red. So an example is, when could I use a surgical mask and eye protection? And that would be a transient contact, low risk. Okay. And that's yours from August the 12th. So hopefully you can access that. It's actually the risk matrix for assessing exposure. It's not actually telling me what to wear, but that's where breaches occur, and they're actually investigating, well, what happened in that ward? Did people have the right mask on? And then we'll assess whether we've got to furlough the staff. Okay, and that we're really short of staff at present. Now, just getting on to the cleaning. With cleaning, the way to sort of look at your practices, and we all, you might say you didn't sign up to do cleaning. Believe you me, we all do cleaning. So with cleaning, it is just application of detergent to a surface, wipe it. And obviously changing the paper towel, etc., between surfaces, unless you can turn something over. But if we're just talking about our high touch surfaces, so at lunchtime and again at home time, you'd be expected to wipe over your high touch surfaces. And they are the handles, the doorknobs, the keypads, the things that we share. I would expect each person in their own little spot to do their own high touch areas. But I'm thinking about the common areas that we touch, the kettle handle, the door fridge, the fridge to the door handle, bits and pieces. Obviously have your own cups and saucers and stuff like spoons, etc. But keypads, what else can I think of? Of course, we tend to leave doors open, internal doors open, for that very reason. Just use our elbow or our foot, and then we're not having to sort of do so much cleaning there. So have a think about what are the surfaces that we all actually need to jump in and do every lunchtime. With a bench, if you do have patients coming to pay Medicare, that kind of thing, and obviously after some things you've got to clean. So after every time the Medicare thingo is used, if the patient comes inside for a second or so, you would clean that. They would do their hands and do it, and then you tend to give it a wipe afterwards. In the clinical area, you would wipe your oxygen saturation device after every use, your stethoscope after every use. Can I provide the names so we can provide? Oh, sorry, that wasn't for me. I think that was from the PHM. So there are things that are wiped over. Now, a little trick about cleaning. I can use a detergent and paper towel, or I can use a detergent wipe. I apply pressure. Wear gloves to do your cleaning, high touch cleaning, etc. Wear gloves to wipe over. Then you say to me, oh, should I wipe it dry? No, not necessarily. Look, it'll be dry in a minute anyway. Then you say, oh, what about disinfecting? Should I disinfect all of these high touch surfaces? Well, you can. There's no sort of have to. What you might look at is a 2-in-1 detergent disinfectant wipe with a catch. If I use one of these and I can see fingerprints on the surface, I use one to clean and then a fresh one to disinfect and leave it wet. If I've already cleaned everything and now I'm going to go along and disinfect it, I'll just use one, leave it wet. Disinfectants all take time to work. And with this one, if I've left it wet and it takes a minute to dry, I've really reduced the amount of virus on that 4 log. What's that? 10,000-fold. That's not bad. It's not sterilising it, but leave it wet. What you can't do is apply one disinfectant wipe to a dirty looking surface and expect it to work. You're effectively just cleaning it a bit. If that's all you want to achieve, fine. So there's a bit of a cook's tour around things, but I do urge you to have in front of you the national guide. You're probably sick to death of guidelines. This is a national document. This is a bit tricky for me, but it says care for individuals with no individual epidemiological risk factors. Well, you could say that's your patient, anybody in the household, anybody been travelling. No. Then it says, and with symptoms consistent with COVID, it tells you straight to go to the P2 mask. And of course, we've got known local transmission. But if there's no known local transmission, it says you can go to surgical. So for some of us, you sit right in the middle there. But if you're seeing those patients outside, you might find the requirement for a P2 mask is much lower. Now, some people will say, I can't see patients outside because, you know, they'd have to sort of park, you know, on a main road, or you're on the 10th floor of a building. And so these are challenges. And so if you are serious about risk reduction and somebody's got to come into a building, press buttons and go up to the 10th floor with their rubbishy old cloth mask, if you want to talk about what's ineffective, well, that's just sort of setting yourself up for perhaps some unacceptable exposure to other people in that building. And I do know with some of the multi-storey buildings, people have actually just set up a bit of a marquee, taking up a couple of car parks and having a look at patients, you know, at the bottom, or the patient calls when they arrive in a car park, and then the staff talk them through symptoms. And yes, come to the door, but don't come in, that kind of thing. So I'm curious to see what some of the challenging situations are that some of the participants have got. And remember, we cannot make it risk-free. People who ask for me I want zero risk, well, the only other thing to do is to not see patients. But then you're going to be in a building with other people. So there's a risk, you know, with your staff. But I think really just going through the symptoms, and we do know that 40% of people at a given point don't have symptoms, you know, while they're infectious. So half of those are just pre-symptomatic, will go on to get symptoms, that's 20%, and the other 20% just don't ever appear to get symptoms. We don't know why. That's just pretty similar with a lot of viruses are like that. Some have a lot of asymptomatic spread. I'm thinking of, what am I thinking of? Maybe even mumps, something like that. Not all is necessarily symptomatic, whereas chickenpox, highly symptomatic. So any questions to date? I'm just mindful of asking. So rather than somebody just telling you something, even from the public health unit, just, you know, stick with this, stick with that. And if you're really, really, really keen, have a look at that on the New South Wales Department of Health to see how you're travelling. But it's really spooky for you to actually have to assess risk yourself, because you're saying, but what if, but what if, what if? But I always treat every patient as potentially infectious, and then I put a risk layer over it. So don't see people without a mask and a face shield. Don't see people inside unless it's absolutely necessary, and don't have waiting rooms. So I'm getting my message across without boring people silly. What else can we talk about? Or have you all had enough and want to just go to bed? Any comments there? Anything there, Julia?
I think you've answered all the questions that we've had in the chat.
Can I hear from people about the challenging layout of the practice in terms of not being able to get air exchange? My pleasure, Leslie. She says it was informative. I hope you're not going to resign or anything. But we are in the middle of a global pandemic, and things, I don't know whether you know, but death tends to follow the first part of the infection by about 4 to 5 weeks. I think that's the sobering bit. We don't have any windows under your front door. Catherine, open it. Okay. And if you've got to put a little barrier up with somebody at the desk saying, you know, you're not coming in, so be it. You know, we've just got to be creative. A little wipe down Bunnings table, $49 if you can get one, and contactless. Patient wants to pay you in cash, don't want it. Yes, the shopping village. Can I tell you, Rosima, I've actually got one client who's moving practice and they're getting a little house to rent and they're very happy. They are sick of being in a shopping centre where they can't even sit patients outside. I did suggest that the minimum amount of time the patients came to the clinic for, they could do by calling the patient just before they came in. But yet, shopping centres, ask first what the air exchange is. Tell me, you know, how many air exchanges are there? And just be really careful about the way, you know, people present it. But the building owner, manager, should know how many air changes there are. But just avoid those situations where you're sitting there chatting to patients. Only inside for that examination, if necessary. And then decide what PPE you're going to use. But I think you can see these things are going to hang around. Of course, any patient who's got a symptom, respiratory clinic, swab, etc., etc. So, you know, we've got to fulfil our duty of care. Our practice has a front door, treatment room has no window. This is where we're vaccinating. Michelle, I think you can answer that question yourself. One clinic I advised yesterday, they said, oh, yeah, okay, we'll stop using our waiting room. And they actually sat the vaccination chair. They made the patients wait outside before and after. But what they did was they sat the vaccination chair right next to the door. So the immunisation nurse could see the patients who'd been vaccinated just outside. And it actually stopped other patients coming for non-vaccine situations, actually stopped them coming in. They sort of saw the nurse with the needle and they thought, better not come in. So have a think about, I'm not using my waiting room now and it's right against the front door. You know, could I use that for my vaccinations? Because patients are actually not coming inside. And that would, you'd get really good air exchange there at the front door, right at the front door. And also I think it would protect the staff in the admin. So if I've got 2 staff previously at the bench at reception, I would just have one. And the other one would be in a room to do all the phone calls. You know how you say to me, I need 2 receptionists, one to sort of attend to the patients and then one to make the phone calls. Well, they don't have to be in the same area and they shouldn't be. Some people have even moved a part of reception into the waiting room and they've actually been able to sort of, you know, do a few things there. But when you are making the phone calls or receiving phone calls in your practice, how hard is it to keep the mask on? You know, you're desperate to take it off because everything's so muffled. Well, you know what? Have your own room. One of my practices, what they actually did was they closed their tea room completely and turned that into their phone room. That's what they did. And nobody came in there except the person doing that. They also got the 2 receptionists to swap halfway during the day because it can be very tiring. Obviously, they had their own set of, you know, their own headset. Don't try and clean headsets. One practice, just really wealthy, they decided that the doctors would not see patients in their room and they had an open door to, you know, treatment room opened outside for emergencies, you know, for patients who had to come in, and they closed the tea room and they installed, I couldn't believe it, a coffee machine in each of the doctors' consulting rooms. Anything to keep people happy. They also set up a marquee outside the practice in the car park and they saw patients there. And they also, you can also have a waiting room, you know, in a little marquee. So there are various ways of doing it. I would, you know, while I'm keen for you to avoid using the waiting room at all, you may be able to use it for other things, is what I'm saying. So with the shopping centre, I think the shopping centre and the multi-floor, you know, practice on the top floor is really tricky. But look at all of the things I've suggested, because every time you do one of those, you're reducing risk. And I mean, my thing is to sort of try to, save practices from being closed down, because that's just a service that we're desperate for, that you provide, and all that we can do. So you can then explain, ask everybody to bring their negative COVID test. I'm sorry, I'm actually not that impressed with that. I don't know what people are going to do. I know they have to do it for surgery, and that's about the best we can do. And I mean, I hear of people insisting on point of care tests, the rapid tests, but really got to be careful there. The pathology collection room, well, you've got to be close, haven't you? Can the pathology reception be moved to the waiting room if it's near the front door? I mean, these are all ideas, and we're really looking for ideas. But no, don't have a fan running and thinking that I'm getting air exchange. I'm not. So good air exchange is something I'd look for, and just reducing close contact. If I've got to have a chat to the patient, if I've had to examine them inside, I have that private chat with them outside on their way to the car park, or call them. So you might find with one patient, one visit is actually in 3 parts. It can be, is the marquee? No, the marquee's open. Okay, somebody's asking. So a visit can be in 3 parts. It might start with telehealth, and the doctor says, oh no, I need you to come in, but don't come in. So I'll come and meet you in the car park. And some of the doctors are saying to me, we actually get the patient to walk around a bit, because we want to see them, how they move, etc., etc. Because we've never seen the patients walk before. So sometimes the visit stops at just the car park visit. Others, a doctor might say, I need you to come inside, I really do. And then patients just inside for those few minutes, hopefully not in the shared consulting room space, or in the space where the doctor's going to take the mask off and do telehealth. So look, some doctors do. They say, it's okay, I've got a really big open window, good cross ventilation. I do my telehealth in the morning, and then the masks are on, and I'll see the patients in the afternoon outside. So you can see that the risk is minimal there. If you do it the other way around, yes, there is still some risk that you've got patients' bugs in the air, but lower than if I didn't have the windows open. So I was going to go somewhere with one of those. So do keep an ear out for what is on the websites, not just what people say. And here's me, barking orders at you. But I'm also saying I stick with these guidelines. And look, there's a bit of a difference between the states. So people will say, oh, I've just been told I'm a close contact. So in Victoria, we would say, oh, that means that where you went was what we call a tier 1 site. And that's where a case has been, and probably spent quite a bit of time there, even the full day, in their infectious period. And they've had contact with a number of people. So I think using the word close contact is important. With the contact tracing, I don't know whether you know how it works, but essentially we want to go back 3 days and see where has the patient, the case, when did they start to get their symptoms? Oh, yesterday. And I had my test yesterday afternoon, and I got my result within 24 hours. We're a little bit lucky here. We're actually finally getting sometimes even 12 hours, we're getting our results in Melbourne. It's difficult if you've got to wait more than 2 days for the result. It's hard for contact tracing to work in time to contact people, to tell them to stay still, sit, quarantine. Some people use the word isolate, but isolate is where you've got the infection. Quarantine is where I'm waiting to see if I'll get the infection. I've been in close contact. With Delta, things have changed. So it looks like the period of incubation is a little bit shorter. So it's harder for the contact tracers to find you, within 2 days and get you to stop. And what else was I going to say about the Delta? Usually everybody in the household's getting it. So before, with Alpha and Wuhan strain, we had a bit of success in isolating the patient the case in their bedroom with an ensuite for 14 days, and the rest of the household maybe 20% chance, 30% chance they'd get it. With Delta, it's nearly everybody. And I sometimes wonder, these really high numbers, are frightening enough, but you will begin to just see it go through the whole household. And so it means that people have now got to, when they do get it, they've now got to count their 14 days. So when we say to people, you've got to stay inside for 14 days, but if somebody else in that household gets it, well, they've now got to count another 14 days. And then they might pass it on to another person that has another 14 days for them. And there were, stories of people in Melbourne last year isolating for days and weeks and weeks and weeks because of potential risk. With children, they have been looking at. There are some studies being done with the vaccines, especially Pfizer and Moderna. This is just looking back at the States. They recruited just not enough kids to look at in terms of the safety of the vaccine. They had a small dose just to see if it was tolerated. But the FDA, Food and Drug Administration, got back to the two companies and said, you haven't got enough people enrolled in the study. I think they had like 77 or something like that in each company, something like that. It wasn't thousands that we want. So the first stage is establishing that the vaccine in a very small dose is tolerated. But I can tell you, and then the next stage would be maybe increasing a little bit or seeing how antibody production is. The key, I think, to viral infection immunity is not so much around antibodies, but around your T cells. So antibodies are produced by, your B cell system, and your T cell is really about viral. So viral infection, what happens is the T cell can actually recognise that the cell is becoming infected and just gets into action pretty well, very quickly. Whereas, this is with immunity, whereas with your antibodies, you've really got to wait until the virus begins to come back out of your cells, it replicates. Yeah. And that can be a little bit later. So we don't go and measure T cells, but we measure antibodies. And we say, well, if you produce antibodies through your B cell system, it would have also kicked your T cell system into action. But T cells are really the key, I think, to producing immunity. People talk about waning immunity. It's possible that we'll end up with a third dose, but it looks like when we get continued exposure to this, as it becomes our, common cold maybe in the future, that we'll just get regular exposure and it won't be so much of a problem. There is some smart money on the vaccine is probably the virus has undergone a number of mutations, and there is some view that it hasn't got too much longer to turn itself inside out to create new variations, but some smart money on that. I'm not putting mine there. In terms of how long immunity lasts, this is really going to be about T cell memory, which is really important. I've got to say that when you have an injected vaccine, you produce your antibodies and T cells through your body. But really, the key for a respiratory infection is about producing local antibody. And you tend to get that by, vaccines that you might be able to inhale. And who knows, that could be the future. Because to produce IgA, which is an antibody, that's about mucous membranes. And to have IgA and IgA memory on your mucous membranes would be just gold. But at this point, all of our vaccines that have passed are injectable. And I mean, those of you who know the story of the polio vaccine will know that we went from injectable to oral, I think in the 60s, because you needed to produce antibodies in the gut, not just in the bloodstream. So, whether we'll end up the same here, I'm not sure. So just going back to children, when they did the studies for the 12 to 16s, I have to tell you, that age group just have a blinding immune response. And so there's no doubt about it. It's the fittest age immunologically, that particular group. So, you can probably see that this is going to work nicely for your 11s and 10s. They really are producing great antibodies. For the younger ones, I know in Russia, they're looking at the 3 to 17, they're enrolled in trials. So with children getting COVID, about 1 to 2% may expect to be hospitalised. I actually think that's very significant. And so this is why we're trying to slow this virus down. This is why we need to slow it down. I don't think there's even if you have a day of, oh, you know, we're not in lockdown anymore, there will still be restrictions. There has to be for many months to come. And we don't know even now whether we'll reach a point of no restrictions. So that is, I guess, the present, and maybe just looking ahead a little bit. And yes, we'd all like it to be over, but that actually doesn't help. We can get angry and that doesn't help. But mainly I wanted to thank you because you're at the front line there and dealing with really tricky situations and emotion and anger. And please get that break every 2 to 3 hours from me. So if that's it, no more questions, I might leave it there. But what I want you to do before you sign off, oh, Huang Tran, you've got a question. Somebody's got their hand up. Have I answered that question? What I want you to do is to think about 3 things that you're going to change tomorrow that reduce risk. If you're perfect, fabulous. I don't know why you're still here. The hardest part is people thinking that we're trying to kill them with the vaccines in 2 to 10 years. You know what? If you believe in natural selection, maybe they're doing it for themselves, because I'm really concerned about people, and they're in my neighbourhood too, who don't believe in the virus, therefore are not masking, therefore are not getting the vaccine. And I think I know what's going to happen to them. They're going to get sick. So that will be the way it will be for people who don't become immunised. Yes, we know that 8 out of 10 adults will recover quite nicely, and of the 20%, maybe half of them end up in real trouble. But it's not always a smooth path. And I can tell you, you know, with a 1% mortality rate, which hopefully will actually go down, and certainly we're seeing the effects of the vaccine now, and you only have to look at the hospitals. I think of around 92 in hospital, only 1 is vaccinated. And I think it's the same story in Sydney too. And I mean, what do we have to do? So, yep, they're in my neighbourhood too, but they're going to get sick. But my concern is they will become a reservoir to pass it on to our immunosuppressed patients. Don't need that. So thank you. And I know it's stressful, and I've really probably got nothing except sympathy to offer, and it's going to get really tough, I think, in the hospitals. That's where a lot of the action is going to be. But if people could have been vaccinated by June, yes, we can wish that too, and it doesn't help to be angry about that. But, you know, until Delta came along, we probably could have managed doing it the way we were doing. But now we're expecting the vaccine to do the heavy lifting, and we will not get herd immunity. You would really have to have, as I said, 85% of the whole community immunised. And in fact, the worst time to immunise people, if you want the vaccine to like create that herd immunity, is during an outbreak. It's really difficult. So we're using the vaccine, I guess, as it's a different strategy. You know, we're using it to sort of just try and build up some overall protection. So whilst you're resting tonight, your body is, you know, making more memory B cells and T cells. We need it to do that. So thank you.
Thank you so much, Margaret. Thank you everyone for attending this evening. I would just like to remind everyone to please complete the online evaluation posted in the chat. And just a reminder, if anyone is sharing the same login, could you please also inform us of that through the chat? So thank you everyone for attending, and have a great evening.
Okay, thank you, Julia.